Hello, good morning, everyone. My name is Damien Gruson. Happy to talk today about the emerging technologies and the perspective for the management of chronic diseases. I am practices in Brussels, very nice place, very nice town, a lot of great monuments, also the foods and so on. We have also very nice hospital. That's my hospital in Brussels, Cliniques Universitaires Saint Luc. And we are renewing the hospital with a project for 2025. There is also the project ongoing for our institution for the switch to a new electronic medical record system by the mid-June 2020, so coming soon. That just illustrating that there is a lot of change ongoing in the healthcare system, and the ecosystem at large is changing, transforming because of the economical pressure, transforming because of the burden of the chronic disease. More and more patients, unfortunately, are candidates for having chronic disease, even if it could be not communicable or communicable. There is the change in the age pyramid with the so-called silver tsunami. More elderly people also more prone to have chronic disease. And the ecosystem is changing also because I think everywhere over the world we have a shortage in the healthcare resources. And the ecosystem is changing also because of the technology. New emerging technology, digital technology are transforming the way we are practicing. And if you are going to the internet, just an example, sorry for the publicity, Amazon, just for example, is working on new healthcare services. The example of diabetes, where they are thinking to have an app and a sensor to measure and play a role in the diabetes care management, is an illustration of new player coming to the field of healthcare or laboratory tests. Diabetes is a great example to illustrate this impact of emerging technology. If you look to the number, over the world there is more than 425 million people suffering of diabetes. It's around 1 on 11. And unfortunately, there is about 1.5 million deaths per year caused to diabetes. Big impact, unfortunately, big numbers, huge morbidity, huge mortality. There is the complication of diabetes, as we know, that will also impact the quality of life of the patient, the need for care. There is a cost also if you consider the cardiovascular complication for diabetes, if you consider the kidney dysfunction related to diabetes, the eye, the diabetes foot, for example. So important in those patients to go for the early risk estimation of complication and try to prevent in contrast to care. So prevention is needed, and the new technology could participate to the prevention initiatives. If we talk of emerging technology, we have to talk about digital health. And digital health is now the third largest industry in the European health sector, just after the pharmaceutical and the medical devices. The numbers are spectacular, more than 300,000 apps available on the market. The number of wearables, balance, steps counter is also increasing. The smartwatches are an example. we have different domains that we could discuss. The clinical or medical information systems. There is the telemedicine, there is the mobile health, and there is the data science. The science of machine learning is something also impacting the way we are and we will manage chronic diseases. The remote monitoring is something that has changed clearly in the field of diabetes. We have sensors that could be used to continuously monitoring the glucose. And the patient, the physician, will see the continuous data from the glucose. The patient will see the number of hypo or hyper, will be able to anticipate some episode of hypoglycemia, and will be empowered in the management of its disease. The platform allows also a dynamic interaction with the diabetes care that could recommend to the patient early visits or some measure that he could adopt. And this connectivity, this remote monitoring, as I mentioned, is more facilitated by the wearables. There is more and more wearables, and according to this French study, there is top wearables that are used, the smart watches, glucometer, the tension, the balance, really tools useful for the patient of suffering for chronic disease. The weight is important to monitor in some condition like diabetes or heart failure, for example. And it's easy to, that's an example where you could easily have the view for the patient, allowing the monitoring of the glucose, the A1C estimation. You can have some gamified coaching, and the connection with the diabetes care, where you have the vision of the different patients to manage, and zoom on the one who could present the digital phenotype, which is with an increased risk. New horizons also through the telehealth, because the connectivity is there, so opening the possibility for virtual appointment, virtual consultation. The patient could have access also to certified educators, be trained or educated through video conferencing, change their behaviors by being empowered. And there is also the telemedicine or the teledermatology for screening of some retinopathies or diabetes food. So more hyper-connected or dynamic or real-time connection. We are, as a specialist in laboratory medicine, also involved in this continuous integration and management of data. And we have control center where we already are able to monitor for point of care, for our own instrument in the laboratory, but also soon for sensors. And that's mandatory to have this control, to be sure that we have the necessary quality control, to see the training of the user, the competency of the people using the smart connecting devices. So, and behind that, say, hello, we have some warning, please do something. So the action, on time action. With these new ecosystems, new technology, we transform the way we are dealing with outcomes. So there is new outcomes because of the emerging technology. Because of the connected device, and we have the opportunity by the prevention to improve some outcomes, be more anticipative to some complication. And I think for this prevention, this early identification of the patient at risk, through the blood test and the integration of new biomarkers, we play a role. The example that I took, this study, we evaluate new biomarker GDF15 and the fibroblast growth factor 23, and they were related to mortality in type 2 diabetes. We know that these two factors are also related to adverse cardiovascular event in population like hypertensive subject or type 2 diabetes. So the integration or the early measurement of these new biomarkers might contribute to these prevention initiatives. And leveraging more data that we could integrate. That's what I call the power of the data, the new DNA, and we are contributor for that. There is several sources of data. The laboratory informatic system, the laboratory data are clearly a big bunch of this data because of the number of requests, because of the number of tests, if you consider the omics, genomics, proteomics, that will help to guide decision or more accurately estimate risk or diagnosis. Data, machine learning, new trends. There is also the trends for distributed learning. So you can, if you have an algorithm relying on the data, you can distribute that to some remote spot in hospitals, in care facilities, and the model will integrate the on-site data, will learn, and will be more and more accurate because of this learning on the real-world data. So machine learning, data science, to have more and early risk estimation, distributed learning to make the evolution of the algorithm learning for clinical and real practices. Data integration is more real than ever because we have also the cloud for the health record. So it's easy from different spots, which could be the primary care, the hospital care, or the patient himself with sensor, to transfer the data to the cloud, integrate, and get more option for to get the clinical decision support from the data. So because of the computing power, because of the cloud computing power, this is becoming real. But we need to carefully drive this if we want to have the augmented laboratory medicine based on the data integration. The framework need to integrate the challenge of ethics, data privacy, the regulation, the legal framework, and how can we finance this new technology and new data. And there is some European country with already efforts or financing for digital application or data science. We have also the ability through the new technology to change the behavior of the patient. Literacy, more educated, empowered patient will be more aware of the risk of the disease. So we can win some quality of life and some time and some complication. The changing ecosystem means also that the patient and the citizen are already going to internet to track the symptoms, track the treatment. So they are users of the web-based interface, and no doubt, and that's the other trend, they are users for the mobile health technology. So they will use the mobile health application to monitor the disease, get tips and tricks for the education, So the transition is ongoing. And that will be helpful to improve the literacy of the patient. This image to illustrate that in Europe, at least 50% of the population is not literate enough, missing information of the disease, the symptoms. And it's also an opportunity to educate the healthcare workforces to new technologies coming from the lab. So emerging technologies are playing a key role for the improvement of the literacy and the education. To the diabetes type 2, for example, the ability to have the food monitoring, dietary counseling. Option number one. More opportunities to get in polymedicated patients, also the case for patients with diabetes type 2, for example, medication reminders, warning for some potential interaction, and the prescription refill reminders are also opportunity offered by the new digital surrounding. And we have groups, social networking, social group to empower the patient. They will discuss in between them about some tips and tricks. Opportunity also to give message. There is new treatments. There is new clinical trials. So allowing by this new digital and emerging technology. We are changing also a bit the way we are practicing. We are living in smart environment, meaning that we are shifting from decentralized care to something which is more distributed, integrated, more and more connectivity between hospital care, primary care, or primary care and hospital care, home care, more use or more integration of resources, more or best use of resources that are connected, interacted, more multidisciplinary exchange also. So the ecosystem, more interdisciplinary, more dynamic, I'm convinced. Going to this important multidisciplinary collaborative care model, where we have different players, the physician, the laboratorians, the pharmacist, the patient, the helpers that will interact in a more connected, interoperable environment. We need to take care to train the healthcare workforces of tomorrow. So in the curriculum, we need to take care that they will acquire these new skills for digital tools, emerging technology, if we want to make the best use of the technology. We of course have multiple challenges to face. What is the real added value of this new technology? Are they interoperable enough? That's a very important question. Are the API not locked? What is the validation framework for this new technology? Laboratorians will play the role, the validation of the new lab devices, the tele-laboratory medicine practices, more advice through the digital channel, challenge for the regulation, challenge for the financing, and we will have financing if we are able to demonstrate the cost effectiveness of the system. We have, fortunately, some recommendation. This example of the draft guideline for the ethical practices of artificial intelligence at the European scale. Cost effectiveness, of course. What is the business model? There is different elements in the literature showing that digital care should or could be cost effective. What will be the way to finance it? Will it be state finance? There is example in Denmark, Germany, with digital application reimbursed by the government, or will it be out of pocket, patient paid? That question that we need to answer, or will it be an hybrid model? I don't know. we will face also the question of the democratization of the access to the technology. We need to take care that the cost will not be too much for a device that could be helpful for the whole community. So that's the go-to-market analysis, and make sure that the majority over the world will be able to use the technology, and we need to support the emerging countries to use this new technology, and the cost will be an issue. Triggers are coming, the example of the 5G, which will make this data digital world more efficient, more faster, more interoperable. That's clear. I think that we should be optimistic on these promises from the emerging technology. Of course, there is the famous Gardner hype cycle, where there is this phase of stimulation. There is this phase of disillusion, integrating the different challenges. But there is delight coming, and we are reaching the plateau of productivity. That will come, or that is coming, at least in already some countries. So be positive, but we are also the important gatekeepers for this transition of technology. So it's not the technology alone, but it's the best use of the technology by the human, best use of resources, and we will succeed and provide new digital enhanced services. Thanks a lot for your attention. We will have a great lecture from Anna soon, and thanks for LabRoots for the opportunity. Thank you very much.
Hello, everyone. Thank you, Dr. Gruson, for that very interesting and exciting talk. And so I guess it is now my turn, and it's my pleasure to be part of this panel and to thank LabRoots for inviting me to speak about mobile health environment and point-of-care testing. My name is Anna Füzéry. I live in Edmonton, Alberta, Canada. I work for Alberta Precision Laboratories, and I'm the North Sector Point-of-Care Testing Medical Lead. I am also a corresponding member of the IFCC Committee on Mobile Health and Bioengineering and Laboratory Medicine, and I'm a Clinical Associate Professor at the University of Alberta. And so today, I am going to talk about point-of-care testing in mobile health environments with a specific focus on errors and what kind of errors may be typical in these environments and what we can do to try to reduce these types of errors. And so my talk is going to consist of 4 sections. I'm going to talk briefly about error classification in point-of-care testing in general. Then I'm going to move on very briefly to how I define mobile health for the purposes of this presentation. I'm then going to talk about opportunities for point-of-care testing errors in mobile health environments. And I'm going to conclude my presentation by talking a little bit about risk mitigation strategies that we can put in place to help reduce these types of errors. So I'd like to start by talking a little bit about errors in point-of-care testing in general. And a good place to start is the error classification that was developed by Dr. Gerald Cost back in the 2000s, early 2000s. The classification system that he developed was slightly modified a couple of years later by Meyer and colleagues. And so the resulting error classification system is illustrated in the table here. And the way that this table works is that point-of-care testing is divided into 3 different phases: the pre-analytic phase, the analytic phase, and the post-analytic phase. And then on the right-hand side, you can see some of the more, I guess, important errors that Dr. Cost and Meyer and his colleagues identified in each of these phases. So the pre-analytic phase was broken down into 4 important parts: test ordering, patient and specimen identification, specimen collection, and specimen evaluation before you actually do the testing. So this is for things like specimen quality, including hemolysis, lipemia icterus, or any other kind of specimen quality issues. The analytic phase was broken down into calibration of the method. So for example, if there's a calibration that's due and the end user forgets to do that or does it incorrectly, that would be an error. Specimen and reagent interaction with each other, the actual generation of the result, and then result validation. And so result validation, for example, would include the running of quality controls periodically or other performance indicators to make sure that the result that is being produced by your point-of-care device is actually accurate. And the last phase that was developed for this error classification system was the post-analytic phase. And most of the things in this category relate to the report that contains the result. So formatting of the report, critical value reporting, any other important result reporting. So for example, if you have some sort of panel and there are certain types of results that are more important than others, maybe there might be a system in place to report those more important results. And report recording and retrieval. So for example, if you have a device that gives you a paper printout and then that printout is manually entered into a patient chart, but a mistake is made during the entry, and so the final paper chart does not accurately reflect the original result, that would be an error as well. And so this classification system was developed in the early 2000s. I think for purposes of mobile health, we can add 2 other categories in here that become important. Oh, excuse me. So one would be infection control, and then the other category would have to do with privacy, security, data integrity, and transmission. And of course, infection control becomes particularly important when we start using a single device on multiple patients. And this would certainly be the case for mobile health environments where we might have access to 1 or 2 devices at most, but we use it on multiple patients. And then of course, for the purposes of mobile health, the whole piece about data integrity and transmission and privacy and security becomes very important as well. And there can be errors made in this phase as well. So I'd like to talk a little bit about what we currently know about errors in point-of-care testing. So I just mentioned the classification system that was developed, but what do we actually know about the types of errors that occur in point-of-care testing, and then specifically in mobile health environments? So I like to liken our knowledge on this topic to this map here, where you can see that parts of the map are very well explored, very detailed in terms of cities that exist and features that exist. And then the top left part of the map is very detailless, and we really don't know very much about that part of North America. And so the things that we do know about errors in point-of-care testing come from a number of key studies that were published by different point-of-care groups who perform quality assurance programs for their various point-of-care testing programs in their hospitals. And so the key here is that most of these studies were done in hospitals. There are almost no studies done in mobile health environments, mostly because of the recent, or I guess the young nature of mobile health. But what we do know from hospital environments is we have a good idea of average error rates. But what I mean by averages is that a lot of these studies did audits of the different point-of-care programs, looked at error rates, but they average the error rates over different types of point-of-care programs. So let's say they had a blood gas analysis program, they had a manual urinalysis program. They looked at the error rates in all of those and just averaged them out. So we have one number instead of knowing the error rate for urinalysis programs or the error rate for blood gas analysis programs. We do have a comprehensive list of quality indicators, and these are based on quality considerations, on different regulatory and accreditation requirements, and then also on that error classification system that I showed you in the previous slide. We also have tools for data collection. So we have error reporting systems, which are systems where either the end users or the point of care groups can log errors that have occurred for record keeping purposes, and also what the outcome of the error was. We also have in-person visits, which excuse me, are sometimes called audits. These are also really great tools to identify parts of the point of care testing process that are being done incorrectly. And then nowadays we have data management software, and this is becoming more important. We're able to connect point of care devices into point of care middleware, and then look in the middleware to retrieve data and to analyze that to identify possible trends or patterns that we may want to troubleshoot. And the last piece of information that we know, which is that in-person assessments, otherwise known as audits, do reduce error rates. So it's important to monitor errors, but it's also important to end users through in-person visits. It gives us an opportunity to establish relationships, also to talk about things that end users may not be doing correctly, and they're received much better than if we just send an email or just some sort of note. Now, in terms of what we don't know, there are quite a few things. So I mentioned that most of the studies that exist to date about errors in point-of-care testing are in hospital environments. So we don't really have a good understanding of errors in other environments, such as in mobile health. We also don't really have a good breakdown, as I mentioned before, about different error rates for different types of point-of-care testing. So are the error rates for manual urinalysis different than for an automated blood gas analyzer? We just don't know. We don't really have also a standardized threshold for acceptable error rates. So, for example, what's an acceptable rate for competency? If 90% of our end users are competent, is that acceptable? Does it need to be 100%? Different groups, I think, will use different acceptable thresholds, but there really isn't a standardized number that's available. We also don't really have a good feel for the rate of adverse events due to point-of-care testing errors. And while we do have a list of comprehensive quality indicators, we don't really know which one of those are the most important. And this again comes down to understanding error rates for the different types of point-of-care testing programs. So it may be that if certain types of errors are more prominent in one program than another, it may be that we may need different quality indicators for that program versus other programs. And we just don't know. The reason that this is important is because as point-of-care testing grows, it becomes more challenging to monitor all of the quality indicators for every single program. Usually most point-of-care groups are understaffed, and so we really have to identify the quality indicators that are the most important for each program in order to utilize the time of our staff efficiently. And then finally, two other important things that we don't really have very good ideas about is what are the most accurate and effective tools for data acquisition. So I mentioned a number of different tools that we have available, but each of those tools has limitations. So for example, error reporting systems are often voluntary, and so it's not always clear whether all of the errors make it into those reporting systems or not. So they may be one piece of the puzzle, but they may not be the best tool to use by themselves to monitor errors. And then the last piece is about frequency of monitoring. So again, we have different approaches depending on the point of care group that does the monitoring. Some groups do it on a weekly basis. Some groups do it once a year. Some groups do it once a month. We really don't know what frequency is the most optimal. So it would be good to get more information about each of these considerations. So next, I would like to move on to a definition of mobile health. Since this presentation is about errors in mobile health, it's important that we all have the same understanding of what mobile health is. So this is actually a tricky question, and I will show you here why. So these are three different definitions from the three different professional organizations for what they consider mobile health. So you can see that in the first definition, the World Health Organization defines mobile health as the use of mobile wireless technologies for public health. The second definition from the World Medical Association is actually quite similar. So it also refers to the use of mobile devices to provide healthcare. And you can see that the third definition, which is from the committee that I am a part of, also refers to the use of mobile technologies to provide healthcare. So these definitions from different professional organizations are actually quite similar. Another thing that's similar across these definitions is that there isn't a very clear definition of the type of healthcare that's provided with the use of mobile technologies. And you know, I wasn't there when these professional organizations drafted these definitions, but I imagine that maybe part of the reason why they don't have a concrete definition of the type of healthcare is because mobile health is really in its infancy, and so we don't know how pervasive it's going to be as it becomes more available. Now, the challenge is that even though these mobile health definitions by professional organizations are quite similar, they're not universally accepted. And so you can see here a definition that I found from a healthcare product company. And so they still include in their definition the use of mobile technologies to provide healthcare. But in this definition, the mobile technologies and the healthcare is limited to the patient. So the healthcare provider is completely eliminated from this definition. So really, this company refers to mobile health in the context of consumer technologies. And then if you look at this definition, which is from a paper that talks about providing antiretroviral therapy in rural Mozambique, this definition does not mention the mobile technologies at all. So here they refer to mobile health clinics, and these being four-wheel drive trucks that are able to reach isolated destinations and are equipped to provide comprehensive health service. So in this definition, the idea of mobile health is not really related to mobile technology. Rather, it's related to the movement of healthcare from a central location out into a decentralized location that's closer to the patient's location. So for my presentation, I'm going to define mobile health as a type of health delivery model that incorporates three different features. So one, there's a geographical separation between an individual and one or more members of the healthcare team. And this separation can be hundreds of kilometers, but it could also be just a few kilometers. So for example, if a patient is in a hospital, but let's say the physician that consults with the patient's healthcare team is at another hospital in the city, So that could also be mobile health. Now the next condition is that this separation between the individual and members of the healthcare team poses a barrier to accessing timely and appropriate care in traditional medical institutions. And the third condition is that mobile technologies either reduce the barrier or they have the potential to do so in the future. And so what this implies is that there may be programs right now that don't necessarily use mobile technologies or use them in a limited setting. But if these programs could greatly benefit from mobile technologies, were they implemented in the future, then they would fulfill this condition as well. And so my experience is mostly with programs that fulfill both the first 2 points. And then with regards to the third point, most of the programs that I have experience with have only limited mobile technologies or none at all right now. But I think it's important to think about these types of settings as well, because I think that they can really tell us a lot and we can learn a lot about what is necessary to have in place once mobile technologies do become so commonplace in healthcare that they are part of these programs. All right, so next I would like to move on to point of care testing errors in these types of mobile health environments. And I'm going to talk about 4 specific opportunities for errors. There are other ones as well, but due to limited time, I'm going to focus on these 4. So opportunities due to environmental stresses, opportunities due to suboptimal operating conditions, opportunities due to inadequate infection control, and opportunities because of limitations in mobile infrastructure. So let's talk about environmental stresses first. So the issue with mobile health environments is that the point of care devices and reagents in these environments may be adversely affected by things like extreme temperatures, vibrations, impact shock, humidity, moisture, pressure, dirt and dust, and other types of environmental stresses that are not necessarily seen in, for example, a hospital setting. And so as an example, I want to show you here 3 different studies that looked at the impact of temperature variations and temperature extremes on performance of point of care testing reagents. And so the first study looked at the performance of cardiac troponin I and BMP testing in modest short-term temperature elevations. And they found that these types of elevations led to false negative results. The next study looked at short-term exposure of glucose test strips and meters to high temperatures and humidity. And they found that these types of environmental stresses produced measurement biases as high as 33 milligrams per deciliter or 1.8 millimoles per liter, which is quite a significant amount depending on the initial starting glucose of the patient. And the last study looked at infectious disease testing, specifically dengue rapid diagnostic tests. And they stored them for 6 months at tropical temperatures, similar to what they would expect to store them in real-life operation. And while they found that these temperatures did not affect performance of a test called NS1 antigen test, they did find that it affected the IgM test performance, and that this test showed lower reactivity with selected samples. So one of the take-home messages from these studies, and an important take-home message, is that you can't make generalizations about the impact of these types of temperature variations on how it's going to affect your point of care reagents. And so it's really actually necessary to, as part of your analytical validation, to examine the performance of your assays under the environmental conditions that are going to be present in the intended setting in order to understand what kind of performance issues you may see with your reagents. And so here the error potential with these environmental stresses is that in many cases, point of care groups or end users will not thoroughly validate the impact of such stresses on their point of care testing systems. And so then when they do use them out in the field, there's a potential for them to be using devices and reagents that have questionable integrity. And because of that, they produce results that are either inaccurate or they may not produce results at all in critical situations. And then end users are stuck. They may have to do some other workarounds, which can introduce errors as well. Now, in addition to environmental stresses, suboptimal operating conditions can also be a problem in mobile health environments. And specifically, these types of environments may not have a well-lit area where the testing can be performed. They may not have a dry area. It may be noisy, so calm and quiet environment is gone. There may not be a stationary and level surface to do the testing. There may not be adequate power, and so forth. So for example, for our iStats that are used in our province, one of the first pieces of instruction that we have in the standard operating procedure is to operate the iStat on a level surface for the entire period of testing. And so two of our programs that use the iStat are the Alberta Stroke Ambulance, which you can see on the left. That's a picture of the inside of the ambulance. And STARS, which is it's a private organization, non-profit organization that is subcontracted by our provincial healthcare system. So they both use the iStat. And so I want you to take a look at the pictures here and think about where you see a level surface here that the staff on these vehicles and aircraft could use to put their iStat for the period of testing. So I don't know if you agree with me, but I don't see too many areas that are level and flat where an iStat could go. So this is clearly a problem. And so the error potential that it introduces is that staff are not able to follow what is laid out in standard operating procedures, and they're not able to use the devices and systems in a way that is really most optimal for use. And so this again either leads to suboptimal results because the SOPs are not being completely followed, or it may even lead to staff trying to do workarounds, and then while they do these workarounds, they may be doing things that they actually don't know if it's really kind of, you know, how it impacts the point of care system and the results that are produced. All right, next, I would like to talk about inadequate infection control. And so there are quite a few studies available that suggest that improper disinfection of shared point of care devices can lead to the transmission of infection from one patient to another. And there are particularly good manuscripts published about this in the area of glucose testing and the transmission of hepatitis B from one patient to another. There's also a really good paper, which is the first one I cite on this slide, that documented that about 30% of glucose meters in a hospital environment are contaminated by blood, and so have the potential to transmit infection from one patient to another. And so because of this, a number of different organizations have recommended that shared point of care devices should be cleaned and disinfected after each use. Now, if we use point of care devices that are intended for point of care testing, so that's how they're marketed, like an iStat or a glucose meter, there are very clear recommendations from the manufacturer about how to disinfect and clean these devices. The problem that we run into in mobile health environments is if we start using devices that are adapted to point of care testing, so they weren't specifically made for point of care testing, but they're being adapted for it, such as a smartphone, there's usually a lack of guidance on how these types of devices should be disinfected in order to achieve complete and adequate disinfection. And I was curious just what type of information is available on this. So I looked in my own smartphone user guide, and there was nothing about any type of disinfection or anything relating to disinfection. The other important piece here is that if we try to apply the types of disinfection that we would use for devices marketed specifically for point-of-care testing, it's really unclear how long these other types of devices like smartphones would last. So if I wipe a smartphone down with a hydrogen peroxide containing wipe and let it stand wet for a couple of minutes, and I do this repeatedly, just how long is that smartphone going to last? And this is really not clear at the present moment. And so the error potential here is of course that with these devices that are adapted for point-of-care testing in mobile health, that we do not adequately disinfect them, and that this can then lead to transmission of infection from one patient to another. All right, so the last opportunity for error that I would like to talk about today is related to limitations in mobile infrastructure. And so mobile infrastructure has many components. You have basic systems and data sources which are required to have the mobile data available. You have gateways which are needed for secure data exchange between your source systems and your devices and applications. You have enterprise mobility management, which is important for being able to manage users of the devices and the apps. And then you have the devices and the user interfaces themselves. And so there's actually not a whole lot that we're able to say about the limitations of these in a mobile health environment, because we're actually still learning to understand how to best utilize this type of technology within more structured settings such as hospitals. And I'll talk about an example here to illustrate my point. So this is a publication that came out this year, and it's talked about an application that was developed at a university medical center for the entry of patient vital signs at the bedside. And so the idea was developed by a nurse and a nurse manager, and they wanted to do this because what was happening in their institution was that they would take these vital signs down on a piece of paper at the patient bedside, and then later, when they had time, they would go to a computer and manually enter the data. And so they thought that if they had an application on either a smartphone or some sort of tablet that they were able to use right when they were at the patient bedside, this would change and improve their workflow and would streamline it. So again, a nurse and a nurse manager came up with the idea, co-developed by the IT team and the nurse team. They then released the in-house app after a couple of rounds of feedback and kind of optimization. But the in-house app, once it was released, was actually not very popular. So there were some clinical areas where the uptake was only 10%. And after some investigation, they found out that the app was unsuccessful because of limitations in the mobile infrastructure. So for example, when the devices were switching between wireless access points, when nurses were basically going from one spot to another, they would lose connection with the Wi-Fi, and so there were missing data entries because during those hiccups or those lost connections, data was not being transmitted into the EMR. And because of this, the nursing groups would then start to modify their workflow to get around these hiccups. So for example, if there were certain rooms where they knew that the Wi-Fi was better than others, then they would start assigning rooms to certain nurses. So a room that had a good Wi-Fi setup, for example, would be assigned to a nurse who was very keen on using this app. whereas a room that had more poor Wi-Fi would be assigned to a nurse who didn't necessarily want to use this app that much. Whereas before, they didn't have these kinds of room assignments. And so they found that these workflow modifications that they did in order to kind of get around these hiccups in the Wi-Fi, they actually led to a much more complex workflow than they had previously. And then in addition to that, there were also some missing functionality in the apps because of the technical limitations and data security that was imposed by the organization. And then not related to mobile infrastructure, but to the infection control piece that I talked about in my previous slides, there were also challenges in properly disinfecting the tablets that they were using. And so all of this led to the app having a really poor uptake amongst the clinical staff, even though it was the original idea was from clinical staff and it was developed in collaboration with clinical staff. And so really, I think what this shows and how it relates to the mobile health setting is that there are many error potentials related to limitations in mobile infrastructure, and it's going to relate to the particular limitation. But because we don't completely understand how to best utilize this type of technology, even in a more structured setting, it's difficult to predict in advance what type of errors will be made in a mobile health setting, which is even less structured and has more challenges with mobile infrastructure. All right, so I would like to finish my talk about point-of-care testing and error rates in mobile health settings by just discussing a few risk mitigation strategies that we can put in place today in order to work on having a really robust point-of-care testing program in mobile health settings in the future. So I think first and foremost, it's really important to think about the point-of-care program and to really evaluate it for error potential, and to use CLSI guideline EP23A, Laboratory Quality Control Based on Risk Management, to help develop a quality assurance program that addresses the key areas for errors and puts in place quality assurance practices for those points. And this we can do today. I think that we can also more thoroughly characterize existing point-of-care testing systems under the conditions that are relevant to mobile health. So I think previously both manufacturers and point-of-care groups and the clinical groups used to characterize point-of-care testing systems within hospital settings and less so in other settings. But I think now that mobile health is growing, it's really important for manufacturers to start really validating these in these mobile health settings that may have extreme temperatures or other environmental stressors. And then also for clinical groups and point-of-care groups, when they do their own in-house validation, to start validating devices under conditions that are relevant to these settings. I think that it's important to start developing and commercially marketing accessories for point-of-care testing that are helpful in mobile health. So for example, we're still lacking a simple and cost-effective storage container for point-of-care devices that helps to protect them from a lot of these environmental stressors that I mentioned. And so point-of-care testing groups and clinical groups are really kind of left to figure out on their own some sort of workaround for this. And finally, I think going forward, it will be important to design novel point-of-care testing systems with mobile health in mind and with an understanding of the key challenges of mobile health environments, and then designing systems that are able to perform robustly in these types of environments. And with that, I will finish my talk. If you have any questions about any of my presentation or would like to discuss point-of-care testing in mobile health, please feel free to email me at anna.füzery@albertapubliclabs.ca. Thank you.